far as I know, there's only one or two MDs who actually go to patients' homes and do wound care in LA, and I'm one of them.
Nice. So it's him, or it's or don't do it.
Pretty much, yeah.
Yeah. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we are so excited to have Dr. Robert Goldberg, a thoracic surgeon and wound care specialist from Los Angeles, California, with us. Hi.
Hi.
So Dr. Goldberg is a highly trained cardiothoracic surgeon who has transitioned his expertise into advanced wound care. He now operates as a mobile wound care physician and surgeon through his company, Goldberg MD Professional Medical Corporation, providing patients throughout Los Angeles with the convenience of receiving expert wound care in the comfort of their own homes. Thank you so much for joining us today.
It's a pleasure.
We're so excited to have you on, and please give us a little bit of background for yourself and yeah.
Sure. Yeah, I'm originally from Russia. I was born and raised there. Did 5 years of medical school there, but had to immigrate in 2008, and they didn't accept anything here as far as my education, so I had to start from scratch. 4 years of college, 4 years of medical school. Then that was only in New Jersey, and then I came to California for cardiothoracic surgery training, and eventually I realized that that field is not for me. So I switched to home health medicine.
Nice.
Yeah.
So I have a personal question. What was like the difference of schooling between Russia and here? I'm just curious.
Russian education, medical education was a lot more classic style. It's a lot more focused on physical exam and history taking and trying to figure out what's going on with the patient without all these CAT scans and all this technology. American education is very focused on the technology and being able to interpret all these results to come up with the best diagnosis. The results of the CAT scans, MRIs, X-rays, and more advanced studies, more advanced tests to come up with the diagnosis and have a very exact diagnosis. But American education was harder.
Oh, interesting.
Yeah, Russian medical school was maybe a couple of years out of 6 was really hard, but here it's every single year is
It all
back-breaking race.
Yeah.
Yeah, it's terrible.
When you're in residency and things like that, like you did residency in Russia. I'm not sure how their system works, but is it also like you have to do nights and all this stuff, or?
Oh no, in Russia I didn't do residency. Just medical
just
school.
came right up.
Just medical school. Yeah.
Okay. Do they have residency?
Yeah, they do. It's almost just as painful as here. Not quite as dramatic because there's a lot of drama here.
Oh, really?
Everywhere. If you've seen Grey's Anatomy, imagine 10 times worse.
Oh no.
Especially here in LA at USC, but it's still pretty painful. Bad hours, bad money. It's
But the cafeteria is great.
the cafeteria in Russia.
No, here.
Oh, here.
Yeah.
Some of them are pretty good. Others are terrible.
My dad did residency in like Fresno, and every day he would come home with like Snickers not the candy bar, but the ice cream. So that's all I know of American medical school and and residency.
Just the ice cream?
The ice cream, yeah, a bunch of Snickers
Okay.
bars, ice cream. So
Yeah, okay. That's not the only thing they sell in the cafeteria.
no, that's
You
that's what we ate.
You can't quite get through 24-hour call on ice cream.
I guess that's
Yeah.
that's what was left probably.
That's exactly.
So it sounds like you actually have a very well-rounded background. You got trained in both approaches. It probably has led to just the level of professionalism and like expertise you bring to this industry. Can you tell us a little more about the industry and kind of your role in it?
Yeah, so wound care is very prevalent. You'd be surprised, especially these chronic wounds, because all the baby boomers are getting old, and they have a lot of health conditions with heart failure, and the heart failure leads to a lot of venous stasis, which is swelling in the lower extremities and the legs, And the chronic swelling leads to chronic damage to the skin and development of wounds. So and because there's chronic damage over many years, they take a really long time to heal if they ever heal.
Mm.
Same thing goes with patients who have strokes in the past, and they have limited mobility, or they have joint issues, limited mobility. They're bedbound. Some of them are, and the issue there is they're always in bed, and in order to avoid any damage to the skin when you're always in bed, you have to be turned and repositioned. And unfortunately, there's no one to help them, most of them. And they develop pressure wounds. Same thing, chronic damage to the skin and surrounding tissues, very hard to heal. So those are the two probably most common wounds. There's some others, some arterial, which is blood supply, insufficiency, usually in lower extremities also. Usually due to atherosclerosis and peripheral arterial disease, they have insufficiency of blood supply to their feet and their legs, and that also causes arterial wounds, which are also hard to heal because in order to heal, you need blood supply. And if you don't have blood supply, there's no way you can heal those.
Gotcha.
And some others, but those are the three most prevalent ones.
So do you specialize in a specific kind of wound, or do you do it all pretty much?
I do all wounds, but the most common ones are the ones I mentioned that I see. Yeah, but there's post-surgical wounds that sometimes they had a surgery, and there's dehiscence, which means the scar just falls apart, and I've had those. There's infectious wounds from some sort of infection. There's others, but yeah, I deal with all of them.
So what is your role in terms of home health? Like, how do you interact with home health and I assume hospice agencies also sometimes?
Yeah, so I usually get a referral. So most of the time it's at some point this patient was in the hospital, and when they get discharged, the case manager reaches out to home health and because they don't have to be in the hospital. The wound care is a long-term issue that can be addressed at home. So they reach out to home health, and they give them the referral, and then the home health, based on the orders they get from the doctor in the hospital, they take over the wound care, and they see them several times a week, and they treat them. But that doctor who saw them in the hospital can't see them anymore because now they're at home, and oftentimes transportation is an issue, so they can't come to the office. So now these patients are at home, and nobody can see them like a specialized trained person professional who knows how to treat those wounds.
Yeah, like can look at it and say what it is.
Yeah, I can look at it, treat it, and clean it properly without like cleaning what's not supposed to be cleaned. And so then these home health agencies, they have several physicians who they partner with, physicians or other groups, and they send a referral, and then that's when, for me, I personally take over, and then I go see them once a week, and then the home health agencies, they continue to send their nurse the other few times a week that the patient needs to be seen, and then I write the orders, and then basically I run the treatment from there.
Do you collab with the primary physicians or any other doctors on the case ever?
Yeah, all the time. Mostly it's done through home health agencies because they are basically, I don't want to say the operator, but they basically
they're like the coordinator.
Exactly, they're coordinator. They coordinate the care. So when it comes to the wounds, they reach out to me, and then I talk to them. But if it's another issue, that also falls on the home health agency to arrange. So they reach out to the primary care physician, and from then specialists and so forth. So
nice.
Yeah, but sometimes when I need like some tests ordered or special medications, there should be as far as medications go and prescriptions, there should be only one cook in the kitchen, right? So that and that is the primary care physician. Should, right? Yeah. That's the ideal situation, but Yeah, they're the ones, the primary physician, they're the ones who should be prescribing all the medications, managing them, because they know the patient the best.
And at least like be aware of them.
And at least be aware, yeah. So that's usually the extent to where I communicate with the PCPs and manage the care together.
Cool. So what makes you or your practice different than other wound care companies in the industry?
It's been really common lately for these very large groups, multi-state groups that send nurse practitioners or physician assistants to see the patient.
Mm-hmm.
And basically these the home health agencies, they partner with these groups, and they send them the referrals and then the patients. What's scary is all these groups, they send they're not really interested in the patients, or at least in my experience, what I've seen, or getting them better. Their goal is to maintain the wounds because that's how they get paid, reimbursed. Yep. And the other scary part is, as long as they meet the requirement of a licensed professional, like a nurse practitioner or a physician assistant, they send them there. It doesn't matter if they have any experience in wound care,
if they know anything,
or they have any surgical experience.
Mm-hmm.
So what I've seen, how the patients get mismanaged by these specialists is really scary. Mm-hmm. So they have zero experience in wound care, and they just come there, they measure the wound, they take some pictures, and they slap some dressings on it, and then they'll leave without actually. So with these wounds, all these wounds require cleaning, right? AKA debridement, where you actually, or surgical or excisional, where you take the dead tissue with a scalpel, with a curette or scissors, you cut it off, mm-hmm. and you leave a clean wound surface. That's how it heals. If you leave that dead tissue, also known as necrotic or slough, all that dead tissue on the wound, it won't heal ever, and it'll get worse, and also it will get infected, and then the patient gets admitted to the hospital and can die. Right. So it can be either local infection or sepsis, and none of them do that cleaning. So really, well, none that I've seen. So all the referrals, maybe they send me the referrals, that I get the referrals after, most of the time after these groups fail these patients, right? And they can't, and they haven't seen any results. The wound is getting worse, and that's most of the referrals that I've been getting, and that's how I know that their goal is not to really treat, not to make the patient better, and that's concerning.
This is like a random speculatory statement, and like slap me if it's wrong, that's fine. But I feel like sometimes there's, at least in home health, there's a lot of like regulations because we function without the doctor on site. Like for example, in a hospital, you have so much medical staff and support staff and stuff like that. With home health, everyone's kind of on their own at the patient's house, given orders or whatever, right? So we understand why it's highly regulated. But like sometimes all this regulation creates a situation where people just want to like meet some bare minimum standard, and then like anything past that is not really concerning.
That's what they do. They just meet the bare minimum. They do the bare minimum that they need to do in order to bill Medicare. Mm-hmm. Again, the patient is not the goal here, or them getting better. Yeah. It's sad and scary.
I don't know if it's scarier and sadder if it's an issue of like ability or willingness.
Yeah.
What do you think it is?
Well, the issue with these groups is both.
Yeah. Or both. That's probably the worst.
Yeah, that's the worst, and that's what it is, unfortunately, because their ability, again, they have no experience or training in wound care, or very little. It's rare to see one with good experience, and there's no willingness. They just their goal is, at least what I've seen in my experience, is to bill and maintain the wound, not to heal it. So, and also the other issue is what I saw a few times is they send these groups to send a nurse practitioner who used to be a nurse, who's actually still a certified nurse.
Kind of technically still a nurse, yeah.
Right. So what they do is the nurse comes, they do the MD kind of service, they bill for that.
And then they come and do the RN service.
And they, on the same visit.
Same one?
The same
on
visit.
the same visit?
And the same visit,
That's
they
great.
bill for the RN service.
Wow.
So then the home health agency comes and does what they're supposed to, their RN from the home health agency, and changes the dressings and then bills like they're supposed to. But then all these agencies, they end up getting audited and fail their ADRs because the Medicare thinks that they're double dipping.
Oh, interesting.
Because they're billing for the same service that this group is also billing. That's what I saw a few times happen.
Wow.
And there's no way to control that. And the agencies, the home health agencies, are like flabbergasted. What just happened? How we failed? We were doing everything we were supposed to. So
yeah, and actually, I mean, from the home health perspective, they are relying on the expert, right? Like, so like, for example, they think that they're helping their case by calling in the wound care specialist or professional and so on, and then get hit with an ADR.
That's what they're trying to do. Yeah, but then they get not intentionally maybe set up, but maybe these groups don't realize, or this nurse practitioner doesn't realize that they should have been doing this. Yeah. Or maybe they do. You never know. But that's the difference. If an MD comes, I can't bill for an RN service because I'm not an RN. So I bill just for the MD service, and then I leave the rest for the home health agency for the rest few times that they come to visit the patient, and they do they do what they're supposed to. And nobody gets in trouble. Yeah. And the patient gets better because they get an actual surgeon who treats them, who treats their wounds. And I've had, most of the time, I've had patients with wounds years in the making, and I heal them within a few months.
So what do you do that's different besides like cleaning properly the wound? Is there anything else, any other kind of elements to this?
Yeah, the big thing is so there's a reason the wound happened, right, in the first place. With heart failure and venous stasis, it's swelling. Mm-hmm. Or lymphedema, also swelling. With pressure, it's pressure. And with arterial lower blood supply, it's no blood supply. So what these groups don't do is they don't address the reason. Yeah. So the wound is a symptom. It's not the disease. The disease is the cause, something that caused the wound. The wound is a symptom. So if you treat the wound, it will never go away. You just suppress the symptom. So the big thing is to reinforce with the patient, first to address the underlying issues. Also, nourishment is a big issue. A lot of these low-income families and patients, they don't have proper nutrition. So what we do is my company works with a lot of resources for free food, and we get that arranged for patients.
Is this like Meals on Wheels or something like that?
Yeah, exactly, Meals on Wheels. Or there's swelling, so I work with the PCP to improve the swelling. But the other thing is the wrapping. You have to wrap in compression dressings the legs to get rid of the swelling, or there's turning. But the other big thing is patient education.
Right.
So, and that's all of these groups don't do. And then these patients, when I come to them after they're failed by these groups, I come to them and I talk to them about it. It's like they never heard of this before. Like, you have a pressure wound, but you should be turning. And you should be every 2 hours, you should be turning to each side to offload the area that you have the wound, or not put any pressure on the wound. Or you have swelling, you have to elevate your legs. You have to either walk or lay down, but never just sit or stand for a long time, because under gravity, all this fluid goes down to your feet or your legs, swells more, they swell more, and you get a wound, or your wound gets worse. So, and that usually repeated. So these groups, they either don't say it or they're supposed to say it, so they say it once and then they forget about it.
Yeah, well, you have to say something like 7 times before
Exactly,
you
and
can say it.
every time you come, so usually it takes me like a month or so, maybe even more, to finally get them to do what they were supposed to do, turn or not take off the compression wraps, because they're painful. They compress.
Right.
So the patient's like, oh, this is uncomfortable. I can't sleep. I'm going to just cut it off and take it off. And then there's swelling and the wound gets worse.
You're like, but you know what's more uncomfortable? A big ass
losing a
wound.
leg.
Yeah, or that.
Yeah, I mean, eventually. And that's actually where it usually heads. That's the outcome usually with all these patients who don't listen. The wound gets worse, gets deeper to the bone. There's bad infection. They lose a leg.
Stage 4.
Right. Stage 4.
We learned.
To the bone. Yeah. Or to the muscle. Right. Muscle still stage 4.
Fat is 3.
Nice. See, you already know.
Now I know I can not do this, but
now you can do wound care.
Yeah, I can make silly comments from the side while pros do it.
And so then they get infected, they lose a leg. So that's often like in a month or 2 of them not following my directions.
Wow.
That's what I have to tell them. And it's, I mean, that gets them scared. It's not my goal to get them scared, but my goal is for them to finally follow the directions.
Follow the instructions.
Yeah, and that's the hardest part. You can just come there and slap the dressing on, and that's not hard. But cleaning the wound, maintaining how clean it is, maintaining communication with the home health, maintaining communication with the patients. One patient, I have my assistant call them every day to remind
them.
Yeah, every day they call them to remind them, and they to remind them to elevate their legs, or to arrange, or to like sign a form for the food, because like, yeah, sure, we want some better food, but it takes a lot of work to get that arranged, and sometimes they don't have the energy or desire to do it. So that's a lot. That's the most work.
I think getting the patient's cooperation generally is often the hardest part.
Right.
And from the consulting end, we have that challenge with customers where like, it's a lot of, so it's not even like a patient who's like bedbound and stuff. You know what I mean?
Right.
It's like an active person who's like in the pursuit of the goal that you're aligned on, but like
for anybody to change the habits is the hardest part. And I've had one patient who's had a wound for many months, almost a year, that I've been treating it, and she's had it for many years. Had it because now it's healed, and she is a big foodie. So she loves some chocolate milkshakes, or go out and have some nice dinner with a lot of salt, and she had the swelling in the legs. So
that's not wound friendly.
Not wound friendly at all. So, and she actually told me, like, well, I just ate a great nice steak with a lot of salt in it, and she felt her wound get worse. She felt increased swelling.
Crazy.
And I'm like, well, why do you still eat that?
Why don't you stop?
So what I had to do is have her start writing down the food diary and then send it to me every day. That reinforced her realizing that I always have an eye, like I always keep an eye on her.
Yeah.
And then when I threw in that the last resort, like, you're gonna lose your legs if you don't start doing this, that really scared her. The food diary, that scare, and months long reinforcements finally worked. So she started cooking her own food and being more vigilant, and in that sense, and the wound healed. So all of that is a lot of work, but
I mean, ultimately, it's worth it. You're giving people their life back. Much.
Exactly. And not something that I've been seeing these groups do. They don't, and
they don't care.
Even sometimes the dressings are correct, but that's just a symptom. You have to treat the underlying cause, and they don't.
Well, it's like taking Tylenol. Like, cool. Your pain's going to go away a little, but it'll come right back. So
Exactly.
Typically, when you get patients after these other groups, do you find that they're more or less motivated than like patients that might come straight to you once they develop the wound?
Much less.
Less.
Because they're at this point, they're like, okay, this is not going away.
They've like accepted.
Might as well accept it. And that's why it's so hard to get them to change their behavior, because they're like, I tried it before, it didn't work, which they didn't try.
Right.
They're referring to all these years of being treated by these groups and the wound not going away. They're like, I've tried everything, it's not going away, so might as well accept it. And that's why it's so hard for me to take over after these groups. It's much easier if they come straight to me from the hospital, or, I mean, they still have chronic wounds. It's still going to be hard, but when they are treated by these groups, they've given up, essentially, the patients, because like, I've been treated for years now, and we tried everything, and
like, how are you different? Like,
what are you gonna say? It's like, you telling me I'm gonna lift my leg for a few hours and the wound is gonna go away after all these cleanings and dressings they've been using? That's nonsense. So they don't do it.
It's like Dorothy in The Wizard of Oz. You had the power all along.
Right.
It was on your feet.
Right. Exactly. Yeah. Exactly.
And I guess my last question is, of course, you're very active with home health agencies, collaborative relationship. Do you ever work with hospice agencies? Have you ever had patients like that?
No, I don't focus. I don't work with hospice because my focus, again, is to resolve.
Rehabilitate the
wound, and heal it. But in hospice, it's mostly maintenance, and the wound care is not the main priority there.
Right.
The main priority is to keep the patient comfortable, and part of that is that you can't really clean the wound properly because that causes a lot of discomfort to the patient. So you want to keep them comfortable, and at that point, you
just use the other group.
Yeah, yeah. You basically want to prevent infection and prevent pain.
Right.
And when you prevent infection, you use very special antibacterial dressings, and that actually, besides the infection, that kill the healthy cells too. So there's very, very little, little chance for improvement in those kind of patients. But my focus is to actually heal the wound.
Gotcha. Well, thank you so much for joining us.
Of course.
This was fascinating, actually. And this is Dr. Robert Goldberg. Please let us know how we can work with you if anybody wants to contact you or...
Absolutely. So my company name is Goldberg MD PC Professional Corporation. And all you need to do is just go online and put in goldberg.md. Nice. That's my website. And there you'll be able to contact us either through the office number or email, and we could always arrange a meeting. And I'll give you one of this, which has my cell phone on it.
Ooh, fancy. Awesome. So this has been the problem with wound care groups. I'm Mariam Treystman from the Home Health Consultant. This is Dr. Robert Goldberg. And if you like our content, please like, share, and subscribe. Thank you.
Thank you.